Hey, this is Dr. Gotham Gandhi, live from Lynchburg, Virginia, Facebook Live. Thanks for joining me, everybody. Just want to give you a little bit of background of our practice and me. First, I'm part of Ortho Virginia, which is the largest musculoskeletal group in the state of Virginia. We have about 120 orthopedic providers, and we're considered the West in Lynchburg. Anybody that's here in Lynchburg and the surrounding area, you probably know that we're being washed away right now with all the rain. We also have Central, which is Richmond, the North, which is Northern Virginia, and then the East, which is Virginia Beach. So, outpatient total joints are, I'm very, very passionate about this. I think this is an interesting topic, and I've done quite a few of these outpatient total joints. They asked me to talk about it, and I want to give you a little bit of background about this. First of all, I'm board certified in orthopedic surgery and board certified in sports medicine. My experience is mostly sports medicine, and then as you evolve in your practice, then you start doing more total joints. I started doing outpatient partial joints, which means only one part of the knee, in 2007. And then I started doing outpatient total joint replacements in 2015. So over the last 5 years, I've done about 300 total knee replacements and about 60 outpatient total hip replacements during that time period, and then many more partial knee replacements. And obviously, since Medicare patients are the primary patients that require total joints, I've done maybe about 5,000 total knees and 1,000 total hips throughout my career, and most of them were done at the hospital. One of the reasons why I wanted to talk about outpatient total joints is that the numbers of these procedures are increasing tremendously. Before COVID-19 existed, epidemiologists and people who follow how many total joints are going to be done in the United States, there's supposed to be maybe 1.2 million total joints done in the United States. Out of those 1.2 million in 2020, a little bit over 10% were going to be outpatient total joints. Well, I mean, that seems like a large number to me, but by 2022, 25%. By 2026, 50%. So you can see the growth is going to be there. So there are a lot of questions associated with it. There's a lot of demand for the outpatient total joints, and then obviously the surgeons have to be able to meet the demand. If you go to any of our practices, just want to preface, I'm not the only expert for doing outpatient total joints. All of us can do outpatient total joints that do outpatient total joints, and it's something that we feel and strive that it's important to provide for our patients. So
they're asking you to speak louder.
So I'm going to speak a little bit louder and a little bit more succinctly, hopefully. So in any case, I feel like I'm qualified to speak about outpatient total joint replacements because it's something that I've done quite a few of over the last 5 years, and I have a lot of respect for the transition from the hospital side to the outpatient side. So what are the benefits associated with a outpatient total joint? Well, safety. There are a lot of new technologies and medications that allow us to do the outpatient total joint in a safe environment in a surgery center rather than doing it in a hospital. When I first started out, I would have never thought that I could do an outpatient total joint replacement. I mean, there's no way I would have even thought about it. But now, with current technology, I feel like that it's actually a safer environment than doing it in a hospital in a lot of instances. Bleeding is a risk. There's a medication called tranexamic acid. We call it TXA. It's very important to take it before the procedure. There's a protocol that we have in place, and that decreases operative bleeding during the surgery, and that's important. We don't want people to have significant swelling and pain and bleeding after their surgery, especially if they're going home. So that's an important part of what we do. Also, some of the techniques, the minimally invasive techniques, that helps decrease the bleeding as well. So by definition, this is a minimally invasive surgery if we're doing it at the surgery center. Pain relief. We don't want to send a patient home if they're in too much pain, so we have perfected some techniques that make pain relief a better option for total joint replacement. The pain relief that we talk about, the anesthesiologists that are at most surgery centers, they're accustomed to being there. Some of them are employed there. They do really good adductor canal blocks. That's a little block to provide anesthesia to the front of the knee. The surgeons that perform the surgeries also are able to do periarticular injections. That means that we do injections all around the capsule and numb the different areas around the knee joint. And the great thing about that is, the patients, by and large, have really good pain relief. And it's something that we're concerned about, and we want people to be comfortable, or relatively comfortable, when they go home. And probably the most important thing that patients are concerned about, and surgeons, is there's a decreased risk of infection if it's done at the surgery center. Well, obviously that's important. Well, if you have the surgeries done at the surgery center, the surgeon usually has a say-so in how everything is run, and so typically the processes are actually run by the surgeon, and so there's less chance of infection for these individuals. Also, in a surgery center, you don't have patients that are hospitalized that require constant monitoring, and so you don't have a sick patient being touched by another patient or another person and then transferring germs to different areas. So surgery center is safer in that regards.
Dr. Gandhi, we're still getting comments that people can't hear you. Could you try and talk a little bit louder?
Okay. All right, I'm going to speak as loudly as I can here, okay? So cost. I need to speak about cost because we're all stewards of healthcare. Cost is very important. We, as a practice, Ortho Virginia and the West, East, North, and Central, the reason why that's important is if we let costs spiral out of control, our premiums go up, healthcare dollars are wasted, and so we really are very attuned at the cost of the procedures. So the most expensive part of the procedure is the facility fee. All the private insurers, Cigna, Anthem, United Healthcare, Aetna, all those insurers have a facility fee at a hospital that pays them sometimes 2 times or maybe a little bit over 2 times the payment of a surgery center payment. So I mean, just for example, a $40,000 facility fee for a hospital would get reimbursed $20,000 for a surgery center, and those costs add up. So I think that's important. Unfortunately for Medicare and Medicaid patients, those are a couple of insurances that we can't do at most surgery centers, and the reason why is because the surgery centers have different payment models than hospitals. Medicaid is a state-run organization, and so the preferred vendor of choice is the hospital, even though it's the most expensive place to provide that type of care. It's unfortunate because these young patients, I would like to take care of them at surgery centers. And even Medicare patients, there are 3 different types of payment models. One is for hospital inpatient, hospital outpatient, and then a surgery center payment. Hospital inpatient and outpatient is very similar reimbursement. Surgery center is about a third less than that, and so it doesn't make economic sense to perform these surgeries at the surgery center because it doesn't reimburse for the implant and all the nursing costs and everything else associated with it. And it's the same type of procedure, it's just the facility fee is different. So another benefit is a quicker recovery. It has to be a quicker recovery. You're going home, and so patients have to be able to walk on it the day of surgery. They have to be able to get into the car. They have to be able to get out of the car and into the house. And so we have studies showing that people do better and have a quicker recovery for most patients. Long-term it's equal success. Short term, it definitely is a quicker recovery. As far as these patients, they're also more motivated, and so that I think that's one reason why they tend to have the quicker recovery. One of the issues that I see is that are all patients candidates for an outpatient procedure? Unfortunately, not all patients are candidate for a total joint. You have to weed out, unfortunately, the patients that are high-risk patients, people with a certain body mass index. In our practice, it's 40, and nationwide, it's very close to 40. We check diabetic control, which is hemoglobin A1C, hematocrits. We do all these things so the patient can get an optimal recovery and an optimal result for a total knee or a total hip replacement. And we want to do that, and we do that not only if you're doing it as an outpatient, but we're also doing it if you're an inpatient procedure. The people who are candidates for outpatient total hips or total knees have to have good family support. I can't do the surgery and you go home and you're by yourself. You can't make food for yourself. You can't fill up your ice machine. You can't take care of yourself. So it's not a good idea to do that. Patients have to be relatively, motivated. They want to be able to go home and they want to be in their own environment. Who wouldn't want to go home? Have you ever seen the hospital beds? I mean, those beds are not comfortable. Most people have more comfortable situation at home, and they're accustomed to being at home rather than in a strange environment. Some people have significant medical issues, pulmonary. If you have poor breathing issues, recent heart issues, those are also indications where it's not a good idea for you to have an outpatient total joint replacement. Now, once you are a candidate and you're going to have this total hip or total knee replacement as an outpatient, you have to be prepared. One of the things that I always tell my patients, have onelevel living ready. Have all your DME supplies, that's durable medical equipment supplies. That means have your walker, your cane. Make sure that you're on one level. That means that wherever you're sleeping, you can have easy access to a bathroom, easy access to your refrigerator, easy access to get ice for your ice machine, your remote control, whatever you feel like is appropriate. That's what you have to do with onelevel living. Now, some of the things that we provide and ask patients to get, that's also important. If you don't take the TXA, the tranexamic acid, there will be increased bleeding associated with any type of joint replacement, so that's important. So follow the instructions. The Polar Care ice machine, that's also important. I like that ice machine. In fact, I have one at home. I'm going to show you a little model associated with it. So it's a sleeve, it has Velcro, and then you wrap around the knee or the hip, and it's hooked with tubing to a cooler, and you fill it up with water and then ice, and then there's a plug-in associated with it. It is an added cost. Insurance companies don't like to pay for it, but it's well worth it, and it's part of the multimodal pain management. We like to have our patients schedule a physical therapy ahead of time. It's important because then that's the one less thing that you have to worry about. Now, we live in the 21st century, so some people can do tele-PT, some people can have a stationary bike at home. If you have access to a pool or other exercise machines and things like that, that's fine, but formal physical therapy is still important. Have your medications ready. Typically, we like to have patients have narcotic medications for short-term use only. We start off, maybe on average, most people get hydrocodone, and then we slowly wean patients off of that medication. An anti-inflammatory is part of the multimodal pain management, Celebrex or any other anti-inflammatory that patients like to use. And then we like for them to have an anticoagulant. It could be something simple like baby aspirin, or it could be something more complex, like injections like Lovenox into the sub-Q fat of your abdomen. Have your food ready. Transportation. You don't want to struggle at your first physical therapy appointment and not have a ride for physical therapy. Have your place of sleep ready. Most people have a hard time sleeping in a bed, so a recliner or a chair is reasonable, and I find that most people are happy with it. Recliner has the little handle, you can get up very easily, and that tends to be a good place for a lot of people to sleep. And sleeping is difficult for a lot of folks even afterwards because they can have dull achiness, and so you have to be able to have that Polar Care ice machine. Is that something that some people use for a month after surgery, and it's definitely well worth it. All right, so some of the common questions, and I think this is one of the great things about the outpatient total joint replacement, because you start thinking about all these different things when patients are home. What do you do with the wound? Well, most surgeons, not all, but I mean, it's usually deep stitches and glue, which is Dermabond. You do the deep stitches and glue, and then you put a waterproof Band-Aid called an Aquacel. The beauty associated with it is the day after your surgery, all the bandages can come off and you can take a shower. You don't have to put new bandages on it because the Aquacel stays for 5 to 7 days, depending on the surgeon and depending on the patient. After that Aquacel comes off, then you have the Dermabond layer, or some people have staples. Then you can take a shower. If you have the Dermabond, then there's nothing that needs to be done. If the staples, then maybe you have to put a light bandage on there. But typically, there's not a lot of wound care associated with the total knees and total hips anymore. I answered the question about when can I shower. That's a very common question. So the first postoperative day for most patients. Do I have to use a walker? If you can control your leg and you're not groggy or dizzy, then you can wean off of the walker pretty quickly. Most people in about a week, they can go from a walker to a cane. And I find people use the cane inappropriately a lot of times. Let's say if you have a right knee or hip, they use the cane in the right hand. Use it in the left hand, and then that gives you additional support. Another thing is you can, as soon as you're able to get off of the cane, then you can go and you're able to get out of a chair, get out of bed, then you can progress without any assisted devices. And probably the two biggest questions that I had, and I'm sure most patients had initially, is am I at greater risk for death for an outpatient total joint replacement? We have lots of multi-center studies. That means multiple centers put their data together, show that the decrease of death and major complications are less if you have an outpatient total joint versus an inpatient total joint. The same can hold true with blood clots. You have a decreased risk of blood clots with an outpatient total joint versus an inpatient total joint replacement. Any questions?
Yes, we have quite a few. First question is, are outpatient total joints done across the state with Ortho Virginia, or is it just in Lynchburg?
The question is are outpatient total joints throughout the state of Virginia amongst our practice? Yes, it is done throughout all 4 regions.
All right. What pre-existing health conditions might disqualify one for outpatient procedures?
If you have COPD, if you've had a recent heart attack, if you have chronic kidney disease, and it's not, if you're on dialysis, obviously, if you have chronic kidney disease, if you've had any type of transplant, those are the most common things. The heart and lung issues are the most common things that we're concerned about. The kidney issues, we kind of get an idea of those things ahead of time. But if you have low-grade chronic kidney disease, we look at certain blood values. Those patients can even be performed at the surgery center.
All right. When does the surgeon decide if the patient is able to go home after surgery outpatient?
Well, the beauty associated with being able to go home, so the question is, when does the surgeon decide when the patient gets to go home? Well, I will tell you the first, 20, 30 total joints, I would finish my surgery, then I would go do my other surgery, and I'd come back, and I would look for my patient that I recently had done in the morning, the total joint replacement, and they had already left the facility. They were already getting up, they were already doing a lot of the exercises, and they were ready to go home. So we have criteria in place. Part of the criteria is, 1, you have to be able to get up. 2, you should be able to go to the restroom. And then 3, you shouldn't have active nausea and vomiting before you go home.
All right. I've heard that in hospitals, physical therapy comes to see you soon after surgery. How soon after I go home doing this outpatient do I start PT?
So the question is how soon you start physical therapy as an outpatient. When you have an outpatient total knee replacement, you are actually doing your exercises as if you're the physical therapist the day of surgery. You're going to do straight leg raises, you're going to do ankle pumps, you're going to bend your leg, you're going to walk. What do you think the physical therapist at the hospital are going to do? They're not going to go over there and touch anything. They're basically asking you to do those same activities that you're going to do that first night. A lot of times the patients can go the next day to formal physical therapy, to outpatient therapy. Let's say a lot of centers have surgery on Thursdays and Fridays, so if you have the surgery on Friday, you do the same exercises, 0 to 90, straight leg raises, ankle pumps, and then your physical therapy can begin next week on Monday, per se. So I operate at my surgery center on Thursday, so a lot of my patients get their physical therapy on Friday.
All right. Is there any difference with anesthesia used for outpatient versus inpatient?
So it all depends on the center. So typically the anesthesiologists at the centers are very attuned about making the patients comfortable afterwards and being able for them to go home safely. In the hospital, that's not required because they're going to be in the hospital. So yes, the anesthesia is more a general anesthetic at a surgery center versus a spinal. And the reason why is because spinals have a much higher incidence of urinary retention. And I've had surgery before, and that's very uncomfortable. And you just can't you can't concentrate on anything else except for you just can't go to the bathroom. And so general anesthetic, less chance of that, much greater chance with spinal. So most surgery centers end up getting a general anesthetic for these outpatient total joint replacements. At the hospitals, most patients end up with a spinal, or a certain percentage end up getting a general anesthetic, but it's almost flipped as far as the percentage.
Right. Is there any difference in training for the surgeon for doing a total joint outpatient versus inpatient?
I think the question is there any difference in training versus outpatient versus inpatient? It's a good question. I mean, I wasn't trained in doing an outpatient total knee replacement or a total hip replacement. It's become a technique that's evolved over time. You have to have a surgeon who's interested in doing it and is accustomed to doing it. And so when I gave you the numbers, currently a little bit over 10% out of 1.2 million are outpatient, but it's going to be 50% by 2026. So I would suspect most total joint replacement surgeons will be adept and good at being able to do outpatient total joint replacement.
What do I do if I go home and I'm in a lot of pain?
The question is, what if I go home and I have a lot of pain? First of all, we probably wouldn't let you go home in a lot of pain, but if you're in a lot of pain and things kind of wear off, so that's the part of multimodal pain management that's helpful. If you go to a center, any place in Ortho Virginia, we have what we call PUNCs, postoperative nurse coordinators. Basically, they help follow up on patients, and they help patients, kind of get through some of the difficulties that may occur. So multimodal pain management means that if you're in pain and you're on Lortab, we're not going to go to Percocet. We're going to stick with Lortab. We're going to add Celebrex. We may add a nerve type of medication like gabapentin. We may add a muscle relaxant. There are ways to help patients without just saying, okay, we're just going to give a stronger pain medication, because we don't want that to happen, because as you increase the narcotic pain medication, people are going to have different reactions, and we're in an opioid epidemic. We feel like we have to be good stewards, and so we want to be able to provide that multimodal pain management.
All right. Are only knees and hips done outpatient, or are things like shoulders or total ankles, other joints done outpatient?
So this is a good question. Are other joints besides total knees and total hips? I can only speak on those two things because that's what I do, but I know in our current location here in the West, we do total shoulders as an outpatient. Total ankles, they don't come across as often, and so the people who do total ankle replacements, the implant cost is extremely high, and because of that implant cost, it's unlikely to get approved in an outpatient facility.
All right. Let's see. Is anything being done different at doing surgeries outpatient because of COVID?
So the question is, are we doing anything different with COVID? Of course. First of all, I mean, it's by the sheer nature of an outpatient facility, it's going to be safer. Technically, it should be a COVID-free environment. But we ask that every patient get a COVID test, quote unquote, self-isolate and kind of be careful after the COVID test. We practice universal precautions before surgery, after surgery. We practice the same social distancing. So yes, there have been a lot of changes associated with COVID with the surgical facilities. So yes, and those things tend to make it safer. So we've tested quite a few number of patients, and from the last recollection in the West, we've had a 1% positive rate, and so we had to cancel that patient that tested positive for COVID.
Where are surgery centers located? I suppose that means across the state. I don't know if you have an answer for that.
So the question is, where are the surgery centers located? So the most important thing that I guess patients should look at is look to see that the surgery center is independent and not an HOPD, hospital outpatient department, because hospital outpatient departments are reimbursed basically the same as a hospital. So there is no cost savings associated with it, and then you have, and sometimes they may be part of a hospital. So it needs to be an isolated facility, and unfortunately I don't know the answers to the whole state, but I know that we have them in every region. There are surgery centers. We have one surgery center in Lynchburg. There's a surgery center in Roanoke. I know that there are surgery centers in Central and Richmond, surgery centers and observatories in Northern Virginia, and then also in Virginia Beach. And those are the only areas that I know of because I'm part of Ortho Virginia.
All right. How long does a total joint procedure take?
So the question is, how long does a total joint procedure take? So typically, from skin to skin, and it can vary depending on the complexity of the procedure, how bad the deformity is. Total hips, total knees, they're similar. It could be an hour and a half on average, sometimes a little bit less, sometimes a little bit more, but that's a good gauge. And typically, that the advantage of that number is, anytime it gets greater than 2 hours, then there can be more anesthesia issues. There can be slightly higher chance of infection. So an hour and a half typically.
All right. When doing a hip replacement outpatient, is a frontal approach procedure done?
So the question is, when you have a hip replacement as an outpatient, is the frontal approach typically done? So I do an anterior approach. That's what it's called, the frontal approach. But in our facility, we have joint surgeons that do multiple different approaches, and they have great success with the multiple different approaches. One approach is not better than the other. It's the technique that's done. And I like the anterior hip approach only for myself because of some of the other benefits associated with when I do the procedure. But any of the approaches can be done as an outpatient.
Why do you think outpatient procedures are less risky? You mentioned studies that have been done that showed death rates are lower at outpatients versus hospitals.
So the question is, why do I think that the death rate is lower and the risks are lower for outpatient total joint replacement? So that's a good question. Most likely, I would say that it's selection criteria. I mean, it is what it is. I mean, we can't stop a positive wave. Multi-center means, not just 100 patients. You're talking about 30,000 patients. And so there's statistically significant difference between an outpatient versus an inpatient procedure. So if you've selected out the people who could have an outpatient procedure, they're going to be the better patients. And if they're going to be the better patients, they're obviously going to have a better health and risk factor correlation. And so they're probably going to do better in an outpatient environment. They probably would do fine in an inpatient environment as well. But now you have a greater number of patients that have greater complex medical issues in the inpatient population.
All right, we have a few people asking about returning to activities following total joint replacements, such as when can I walk my dog, when can I coach soccer again? Can you just touch on how you know to return to regular activities following a total joint replacement?
So how do you know when to return to regular activities after a total joint replacement? It's follow-up. I mean, I don't want you to do it blindly. I mean, typically, in my own practice, I see patients back at 2 weeks. I have a mid-level provider at 4 weeks, and then I see them back at 8 weeks. It's a lot more than what I used to do, because what I found is there were a lot of questions associated about when should I do this, when should I do that. And then in today's world, there's so many pieces of paper that need to be signed. They're like, when can I return to work? When can I do this? So I typically tell most people by 6 weeks to 8 weeks, you should be able to do most of your normal activities. Same time as when you're driving a car. But the minor swelling, the discomfort, even and nighttime issues, that can take a fair amount of time. I mean, you got to imagine you're cutting everything out of the knee and putting a tibia, you're putting femoral component, you're putting plastic between it, you're putting a kneecap behind the original kneecap, and so it's a very invasive procedure, and so all the different things have to kind of return. So as far as the nerve endings, the blood vessels, the minor little small blood vessels, and so people can have swelling and minor discomfort up to 6 months, maybe even a year after surgery, and so that's not abnormal. So people can return to normal activities, maybe even get back to a lot of their kind of quote-unquote athletic activities, but still they're going to have discomfort in their total knee or total hip for quite some time after their procedure.
Are all of the outpatient procedures done at Ortho Virginia surgery centers, or can they be done at other outpatient surgery centers?
So are all Ortho Virginia total joint procedures done at Ortho Virginia surgery centers? Well, I'm in the West. The facility that I use is not owned by Ortho Virginia. It's owned by 50% hospital, 50% many different surgeons, and so that's the ownership, but it's run by physicians, 51%, 49% hospital, and so that's one example. But yeah, it could be done at any facility that the surgeon has privileges. So the surgeon has to have privileges in the facility that they're performing the procedure, and they have to have a comfort level. I mean, if you're doing a total joint replacement and you've never been to that facility, as a surgeon, it can be a scary proposition, because you don't know that facility, you don't know the staff that's there, and so it's something to think about.
Does Ortho Virginia use computerized models to perform total knee replacements?
question is, does Ortho Virginia use computerized models to perform total knee replacements? So, I mean, that's a good question. I mean, typically, you know, there are some more customized things that can be done, and that can be done in outpatient. Computer navigation has not been shown to be any more beneficial than surgeons' experience. The couple of downsides associated with computer navigation is that you have to have what we call pins that go into the femur and the tibia, and these pins are done to figure out where you are in space, because I've done computer navigation knees, and so unfortunately that can increase bleeding, increase your complication rate as well. Also, the length of incision is longer. So yeah, computer navigation, it is one of those things that can be done well. I'm not saying that it's bad or good, but in our facility in the West, we don't use computer navigation.
Let's see. Can you get something ahead of time to help with nausea after surgery?
The question is, can you have a medication ahead of time to help with nausea after surgery? So at our surgery center here in the West, in Lynchburg, the anesthesiologist gives you a anti-nausea medication ahead of time, and if we know ahead of time, we'll send a prescription ahead of time to your pharmacy so you can pick it up as well, or you can remind the surgeon and the staff, and then we can make sure that that's there as you pick up the other medications as well.
What can be done to get into a one-level house that has 10 steps to enter the home? It's kind of asking about adapting their living situation if they have steps to get into their house.
So the question is, how do you get into a home that's a one-level house but there's 10 steps? So it depends on who's helping you. If there's a railing, you can hold on to the railing. A good technique is up with the good, the non-operative leg, and down with the bad. So you can actually, with assistance, go up the steps. If you just don't feel like you can handle it and you're a little woozy or whatever, you know, if worse comes to worse, you can scooch on your bottom and push yourself up the steps. If you know ahead of time, some people can make a little ramp for you, but I wouldn't recommend the ramp, because the ramp is very short-lived, because you should be able to navigate steps very soon after your procedure.
All right, so we're going to wrap up with a few questions that kind of tie back to the beginning for those that joined late. How do you know if you are a good candidate, and this is a little bit more broad about joint replacements in general, not just outpatient, but for how do you decide if it's time to have a total joint replacement?
So how do you know if you're a candidate for a joint replacement? So the most obvious sign is pain. If you're having pain in your hip and knee, then that's the first sign. You have to have radiographic images. You have to have conservative care. We don't want to do that first line of treatment. We want to make sure that you've tried other modalities to help. And typically surgeons for total hips and total knees, you know, it's very rare. I mean, I've had some people who've had multiple modalities and treatments by their primary care doctor that I ever sign up surgery first time I meet them. I mean, it's usually we get to know the patients, figure out what's going on, try some more conservative measures, and then we proceed with the surgical intervention. And then once that decision is made in the office, that's when we do the blood work and make sure, and we know ahead of time about the weight, you know, as far as body mass index, and then we can proceed towards a total hip or a total knee replacement or total shoulder or total ankle replacement.
Let's see. Someone asked, do we rent polar care machines?
So the question is, do we rent polar care machines? I wouldn't recommend it. I mean, if you look at this thing, I mean, this goes around your leg, and it can, you know, there's bacteria everywhere. It's bacteria on our skin. So imagine if that gets on one person, and then they bring it back, and then you give it to somebody else. So, I mean, there are people who will let you borrow their old polar care machines. Make sure you use Clorox wipes and wipe it down really well, and you know, my polar care machine that I have is used for two of my daughters that had ACL surgeries, and so yeah, I mean I know how to use it, and I think it's fantastic. It's a great device, and it's part of that multimodal pain management that I mentioned earlier.
Is there a specific body mass index indicated for total joint replacement, specifically for outpatient, I suppose?
So we don't differentiate between outpatient and inpatient. Our studies show a much higher complication rate with your body mass index greater than 40. So we all at Ortho Virginia limit our body mass index at 40. So if you're even 40.05, I cannot schedule you for surgery. It has to be below 40. And so even though it's just a minor number, unfortunately, just the way our system works, if we don't follow the rules, then you know we'll have many different outliers. You know, then we'll start saying, well, why didn't you? If we did it for that, why can't we do it for 41? So just because of the increased risk associated with complications, infections, it's just safer to get the body mass index below 40.
We had a few people say they joined late and missed what you said about Medicare paying for outpatient total joints. Does it pay for it or does it not? Can you have Medicare and get an outpatient joint replacement?
So the question is, can you have Medicare as an insurance and pay for an outpatient total joint replacement? So we all accept Medicare, and so some people ask, well, can I just pay for it? I can't do that. I mean, I accept Medicare, but it's not that. It's the facility fee. So there's 3 different payments. One is a hospital inpatient, one is a hospital outpatient fee or reimbursement, and then the other is a surgery center payment model. So this would be a good thing to talk to your legislators. There should be only one payment model. Why have 3 different payment models? If you have one payment model, just make it a hospital outpatient department, and then it could be feasible to have outpatient surgeries done at a surgery center rather than a hospital-owned outpatient department or a hospital inpatient. So currently we cannot do these procedures at the surgery centers.
All right. What resources do you recommend to read to prepare for your total knee or hip replacement?
Question is, what resources can you read to prepare for your total knee and total hip replacement? Most facilities have a joint book, and so that will be a good good reading material. And you know, a lot of the questions that aren't in the total joint book can be answered by maybe a friend or somebody else that has had the hip replacement or the knee replacement.
All right, so we're going to wrap up with our last question. Just as an overview, can you just state what would you say is the biggest benefit of an outpatient total joint replacement?
So as an overview, it's a great question because there are a lot of benefits, but what's the biggest benefit of an outpatient total joint replacement? I would have to say safety. I think it, you know, based on the multi-center studies and in our current environment, it's safer to have an outpatient total joint replacement than to have an inpatient total joint replacement.
All right. So we just want to let everyone know that you can re-watch this after this event on our Facebook page. So if you want to come back and listen to something that was said at the start of the video, or just re-watch this, you can find it on our Facebook page, and we will do a summary of some of the questions to be added as resources on our site as well.
And don't forget to share it on your Facebook page. Thank you.
All right, thank you.
All right.